good morning here, but good afternoon to everyone internationally. And thanks for the introduction. So here to talk about one of my more recent studies, looking at opioids for workers with low back pain. So before we begin, I'd just like to note that this presentation uses data supplied by WorkSafe Victoria and Return to Work South Australia. And the views expressed in this presentation are those of myself and my co-authors, and are not necessarily the reviews of WorkSafe Victoria or Return to Work South Australia. And I'd also like to thank both organisations for supplying data in the study. So guidelines for low back pain recommend the prescription of opioids as a last resort, really. And if they are prescribed, they should be used in a low dose and for a short duration. And there's actually limited evidence that opioids provide clinically important benefits to pain or disability. So in a systematic review of 20 trials, which 13 evaluated the short-term benefits of opioid use, over half of the participants withdrew owing to either adverse effects or lack of efficacy. And there are well-known adverse effects of opioids, including overdose, dizziness, sedation, and depression. And long-term use can be associated with addiction and analgesic intolerance, so whereby people need more opioids for the same analgesic effect, leading to a need for greater doses and subsequently further potential side effects. And low back pain is prevalent among working age adults. It's usually self-limiting, but can often be recurrent and can cause significant disability. And it's a common reason for seeking income support from wage replacement systems such as workers' compensation. So in a 5-year period in Australia, there were over 56,000 workers' compensation claims longer than 2 weeks for low back pain. And these claims had a median duration of time loss of just over 9 weeks, which represents a fairly significant proportion of disability for these kind of workers. And workers' compensation systems fund healthcare in addition to wage replacement, and this can include medicines such as opioids. And previous studies indicate that between 9 and 30% of workers with low back pain receive opioids during their workers' compensation claim. And the provision of opioids to compensated workers, in particular with low back pain, is associated with increased health service costs, greater risk of surgical intervention, and increased likelihood of continued opioid use and longer wage replacement. So really negative outcomes. Previous studies have also examined opioids in terms of adherence to guidelines. So for example, the adverse impact of early or non-guideline adherent opioid use on healthcare and work disability outcomes for workers with low back pain has often been reported. And the prevalence of long-term opioid use and linked with wage replacement duration is less reported and mostly reported from North America. And we know that healthcare systems vary internationally. We don't really have much information from Australia until now. So in this study, we sought to identify and characterize opioid dispensing intensity and duration patterns in Australian workers with accepted workers' compensation claims for low back pain, and determine the association of opioid dispensing patterns with wage replacement duration. So Australia has workers' compensation schemes in each state and territory, so there's 11 in total, and this study was conducted using data provided by workers' compensation regulators in the states of Victoria and South Australia. We selected these schemes based on the availability of their data, so not all workers' compensation schemes in Australia record exact medicine details. It's really only these two that record that data. And these schemes provide coverage for approximately 3.7 million workers, or about 32% of the Australian labour force. During the study, wage replacement was available for up to 130 weeks for these individuals, so that's 2.5 years. And both schemes also pay for healthcare during a claim and for a period of time after wage replacement ceases. And we included these from these jurisdictions at workers aged 15 to 80 years with an accepted time loss claim. So that's 1 or more days wages replaced by the workers' compensation system for low back pain with a date of onset between July 2010 and June 2013. We go from July to June because that's Australian financial years. So it's 3 Australian financial years worth of study. We have claim level data that includes sex, age, occupation, socioeconomic status, and remoteness. That's one record per worker. And these are the kind of variables we've used in these studies before. And in services data, that's multiple records per worker. We have the medicines data. That is really the focus of our study. So all medicines were cleaned and assigned to anatomical therapeutic chemical codes, the WHO standard for medicines. And we identified weak and strong opioids using two previously published pieces of literature that have defined those categories of opioids. In the cleaning process, we're able to tell if an individual type of medicine had been dispensed, but we weren't able to tell the number of doses reliably in that dispense of opioids. So counts of opioid dispenses are used in this analysis, but an opioid dispense could include, for example, 28 tablets. The number of opioids reimbursed each 90 days from the reported date of onset was calculated. And given both jurisdictions had different payments, limits on payments for healthcare, we censored opioid payments at 2.5 years. So every 90 days for 2.5 years, 900 days, 10 intervals of opioids, and the number of opioid dispensers at each of those intervals was calculated. For our analysis, we used group-based trajectory models with 1 through 6 groups and 1 through 4 orders of polynomials, so 24 models in total were tested. The final model selection was based on EPICOH information criteria, Bayesian information criteria, and explanatory parsimony. We then produced some descriptive statistics and statistically compared opioid dispensing patterns. And we used quantile regression and Cox regression to analyze the association between those dispensing patterns and wage replacement duration. So if we have a look at these trajectories, the sample included a total of 9,619 workers with accepted time loss claims for low back pain between July 2010 and June 2013. The majority of workers, about 2/3, were not dispensed any opioids during their claim. So the remaining third were dispensed opioids, were assigned to 3 trajectory groups in a cubic polynomial model. So we went for a 3-group, 3-polynomial model. 2/3 of those who received opioids were assigned to the short-term low-volume opioid dispensing pattern, as you can see. Almost a quarter of those dispensed opioids had a long-term moderate volume opioid dispensing pattern, and the remaining 7.5% had a long-term high volume opioid dispensing pattern. We found minimal variation in demographic characteristics between groups. There were some interjurisdictional differences between South Australia and Victoria. For example, there was a greater odds of being a worker from Victoria in the higher use group, although this may have been due to data quality and how we designed our models. Here you can see some detail about the opioids dispensed to each trajectory group. The figure shows the median cumulative dispensed opioids per worker at each 90-day interval. As you can see, the short-term low-volume group received very few opioids overall, only 3 dispensers of opioids. And the majority of those receiving opioids are therefore receiving a median, as I said, of 3 opioid dispensers. However, the 2 long-term groups, as you can see, are receiving very large volumes of opioids over a very long period, up to 72 in the high-volume group after 2.5 years. Those workers who did not receive opioids had a median wage replacement of 7.1 weeks, while the median duration was 30.7 weeks for the short-term low-volume group, 126.9 for the long-term moderate volume group, and 126 in the long-term high-volume group. These similarities in wage replacement duration observed between the 2 groups with long-term opioid dispensing patterns are shown here in these stratified survival curves. The relationship was not proportional for our Cox model, so this is just a stratified model. They're really just Kaplan-Meier curves. And the curves you can see tend to tail off at 130 weeks, which is the censor point, it's the upper limit of wage replacement in these jurisdictions. So it's what we would expect. All 3 models, all 3 opioid trajectory groups, had significantly longer wage replacement duration than workers who had no opioids across all percentiles in our quantile regression model. So for example, with all covariates set at reference values, those who did not have any opioids had 1.3 weeks of wage replacement in the 10th percentile of wage replacement duration. In the same percentile, those in the short-term low volume group had an additional 2.3 weeks of wage replacement. The long-term moderate volume group had an additional 39.6 weeks, and the long-term high volume group had an additional 28.6 weeks. Similar patterns, but with longer durations were observed in the remaining percentiles. So receipt of opioids was associated with significantly longer periods of wage replacement, and the proportion of workers with accepted time loss claims who received opioids aligns with what we know from some North American studies. It's consistent with other studies that we have a small group of people that have a very, very large amount of opioids over a long term. And yeah, it's effectively what we would expect. It's important to note that we didn't have information about dose for these opioids, so we can't have a full insight as to what these people may have had. So we benefited from a large multi-jurisdiction sample, attesting to the robustness of our findings, but it's important to note that we cannot draw causal inferences about the relationship between opioids and wage replacement duration. Potentially important covariates such as pain severity, psychosocial factors, and recovery expectations were not available in the data. For example, people with long wage replacement duration and high volume of opioid use could just be at much higher pain levels than others. So for the future, it would be great to have, as I said, more information on pain severity and also more information on dose. Some other studies have measured opioid use in terms of morphine milligram equivalents, and that would probably be a better outcome than our counts of opioid dispensers. So I'll be continuing some of this research as part of the Australia and New Zealand Low Back Pain Research Network. Thank you for your time.